Evening all. We're just going to give about 30 seconds for people to join in and being let into the webinar, and then we'll kick off. So right, it's time. A very good evening, ladies and gents, and welcome to our 7th episode of the British Hip Society Midweek Special. I'm Vikas, Khanduja, consultant orthopedic surgeon in Cambridge and chair of the education committee in the BHS, and it's certainly a pleasure to welcome all of you to this webinar. Now, our aim with this series, as you're well aware, is to bring to you clinical cases and discuss nuances of decision-making and management from key opinion leaders in the UK, so that we can continue to fulfill our society's manifesto of sharing knowledge and improving patient care. We've already had 2 excellent sessions on the young adult hip, and the session today is dedicated to avascular necrosis. We've had a stellar faculty joining us for this webinar today, including Mr. Callum McBryde from Birmingham, who's been here on this show before, Mr. Nikhil Shah makes an appearance from Brightington, and Mr. Johal from Norwich. Thanks a ton, guys, for giving up your time for this. We're also delighted to be collaborating with OrthoTV Global for this series, and welcome all our viewers from the Asia-Pacific region who are able to watch this event streaming live at no cost via OrthoTV. Thank you very much, Ashok, for this endeavor. Now, we strive to make every session as interactive as possible, and therefore, please do post in your comments and questions in the Q&A box. Our panelists will answer some of these questions as we go along by answering them in the Q&A box, or we'll choose some to discuss at the live at the end of the webinar. Now, for those of you who are not able to join us live, we do have the option of on-demand viewing via our educational platform Panopto, and you can certainly watch it there. So once again, a very warm welcome, and hope you enjoy this evening and also the series. Without much further ado, a warm welcome to Mr. Johal, who will kick off the series. He's a consultant orthopedic surgeon in Norwich, revision hips and primary hip arthroplasty as well, and has got a huge experience in AVN. Sim, over to you.
Thanks, Vikas. Thanks for inviting me to this webinar. Can you just see the presentation? Can I just check that everything's okay?
All good, Sim.
Okay, perfect. Right. So this is there are 3 talks in this webinar, and I'm going to go through essentially the pathophysiology, the classification, and the medical treatment. And I know that sounds like the most boring talk, and we'll get to the case presentations later, but this is important to understand as well. Firstly, I have no disclosures at all. So as an introduction, this is quite simply osteonecrosis, or interruption of the blood supply to the femoral head. About 10% of all hips in the UK are performed for this indication, but across the world and in Asia, it's significantly higher. It's more common in men, and they tend to be a younger demographic in their 30s and early 40s, whereas the females tend to be slightly older, hence average age of about 58. Prevalence is about 2 per 100,000. And what we often see in our clinics on a practical basis is that often patients are delayed in the primary sector in primary care for a significant amount of time, because what really is needed to diagnose this is an MRI scan. So the pathophysiology, there's been numerous theories postulated, but essentially necrosis happens because of ischemia or direct toxicity. The ischemia can be intraluminal, so phenomena such as emboli, sickle crises, or extraluminal, where there's increased pressure around the blood vessels as a result of hypertrophy of the fat cells, and this is due to steroids. And this leads to a compartment syndrome type phenomenon. Alcohol is also directly toxic. So the risk factors, the main 2 risk factors are corticosteroids and alcohol, and those 2 make up probably 75% of all cases. There are a number of idiopathic cases, and then the other risk factors that you can see make up the rest. So in terms of classification systems, now we all remember what we revised for our FRCS, but looking through all the literature, there are 16 major classification systems that comprise 85% of, four systems actually account for 85% of all the literature. And that's the Fiket-Narlet, Steinberg, ARCO, and the Japanese Association classification. But the critical point between all of these classification systems is determining the hips which are pre-collapse and the hips which have collapsed, because as you'll go on to see later, the management is significantly different. Now, none of these systems have particularly good inter-observer or intra-observer reliability amongst surgeons or radiologists, moderate at best, really. But if we go through, firstly, the Fiket-Narlet it's an X-ray classification, and it started as 4 separate entities. And essentially, the difference is between 2A and 2B, where you get the change from pre-collapse to a crescent sign or starting of collapse and flattening of the femoral head. Steinberg, essentially Steinberg used the FECAT classification at the University of Pennsylvania to actually develop his own classification, and this involves the amount of femoral head affected. ARCO is the Association of Research Circulation Osseous, and this group of researchers devised this system in the 90s, and it's been revised a number of times. And there was actually a consensus meeting in 2019 where Dr. Mont was present, along with a number of other experts, and they came to a consensus to try and simplify the classification. And this is really what we should be using going forward. 4 stages, 1 being a normal X-ray, an abnormal MRI with some low signal intensity, 2 being the start of some focal osteoporosis or cystic changes on the X-rays, but no evidence of subchondral fracture or collapse, and stage 3 of an ARCO showing subchondral fracture. And these can be divided into early and late, and then 4 with frank arthritis. The Japanese classification involves the location of the lesion. So they all have their similarities, but the take-home message is that it's important to understand the importance of the pre-collapse hip and the collapsed hip. And moving forward, we really should be looking at the ARCO 2019 classification. So overall, the classification systems, some of the early classification systems, such as Steinberg, looked at the size of the lesion, and that was important because medial lesions tend to be small and progress slowly, whereas lateral lesions are large and do badly. And the amount of femoral head depression does correlate with prognosis. So this is a series, well, MRI is number A, but a series of X-rays showing the natural history of avascular necrosis from stage 1 to stage 4 of the ARCO system. And we can see that the difference between C and D is essentially the distinction between a hip that we could potentially preserve or a hip that is committed to a hip replacement in the future. So on MRI, early stages show simple edema, and later on, there is low signal on T1 and high signal on T2. And what you really look for is this double line sign, which separates normal bone from infarcted bone. And that's pathognomonic, really, of avascular necrosis. So as with most things in life, size does matter. And in 1974, Kabul in France designated the necrotic angle. And this again goes with the theory that bad lesions, big lesions do badly, small lesions do slightly better. He found that there were poor outcomes if the arc of involvement of the lesion on the AP and the lateral view combined was more than 200 degrees. And this was initially used to guide osteotomy. Ha in 2006 in Seoul looked at this on MRI scan with the mid-coronal and mid-sagittal slices and found that whether people have core decompression or non-operative treatment, less than 200 degrees, you generally have an excellent result. Above 250, there's very poor results. So it's important to try and stratify the size of the lesion you're dealing with. So we all know the patients that come to clinic with an asymptomatic lesion. Now, what do we do with those? Again, NAM in 2008 published in the JBGS that observation of hips over 5 years showed that if less than 30% of the head was involved, 95% of people were still pain-free without any treatment. Okay, and this dropped to 17% if more than 50% were involved. So essentially, large lesions, be more aggressive. Smaller lesions, they can be observed for a time. So when I was asked to talk about the medical management, this is the best paper from the Wrightson group, Tim Bordenas and Rajpura. I was lucky enough to do my fellowship there, but essentially a lot of these slides come from them. So we've talked about the pathophysiology being intraluminal, extraluminal, or direct toxicity. This is just a pictogram showing the various treatment targets, and we'll go through those quickly now. Now, the bisphosphonates have really had the largest press and the most literature written about them, and actually it's quite common practice to use bisphosphonates as an adjunct to surgical therapy. So we all know that they reduce osteoclast activity, they reduce remodeling and increase bone density, and they can potentially reduce collapse. In Norwich, I'm fortunate enough to have a metabolic bone unit with a very active and engaged professor who is very keen to see patients who will start them on bisphosphonates. And randomized controlled trials have shown significant superiority for people treated with alendronate compared to the control group over a follow-up of 24 months. Mylaprost is a vasoactive compound. The problem is there is some research to back it, but it's IV administered and has significant side effects of headaches, so it's very rarely used. Enoxaparin, we use this very commonly for venous thromboprophylaxis, and there is some studies to show that there are good results with this from Glueck et al., a follow-up of over 2 years showing significant preservation of the hips treated with enoxaparin, but there are the problems with anticoagulation. So as we move through, statins potentially decrease the fat cell size and can decrease intraosseous pressure, but there are no real great trials for statins as yet. We've all heard of hyperbaric oxygen therapy and shockwave therapy. There are some early RCTs, but the applicability of hyperbaric oxygen is limited, clearly. Now, clearly, as with everything, research is needed. And I came across this NIHR-funded trial called the MANTIS trial looking for bisphosphonates versus placebo. And I believe that Callum, McBryde and Vikas Khanduja have been involved in. But unfortunately, that's been stopped due to problems with the recruitment. So in summary, this is necrosis of the osteocytes due to ischemia or toxicity. It's really important to note that an MRI scan is required. There's often a delayed diagnosis. We do need to be using the ARCO classification moving forward, and this has been the consensus opinion. And larger lesions have a poor prognosis. And it's important not to neglect the medical therapies as an adjunct to surgery. And bisphosphonates probably have the most evidence around them. Right. Apologies for how much we did there, but there's a lot to get through.
Thank you very much, Sim. That's excellent. Yeah. That's a good intro to AVN and also the medical management of the same. Now, Callum will take us through the conservative procedures for AVN. Callum McBryde, as you all are well aware, well-accomplished hip preservation surgeon in Birmingham, also does a lot of hip resurfacing. So, Callum, do enlighten us on preserving the hip in AVN.
So thanks very much, Vikas and Sim, for that great overview. And as always, you learn quite a bit from these things that you think you should already know. So thank you very much. But I'm going to be talking about the different type of hip preserving techniques that can be used in AVN of the femoral head. Clearly, I'm from Birmingham. I'd like to point your attention to OrthoSearch, OrthoMedia, and Non-Arthroplasty Hip Registry. And please take a look at those, please, and contribute if appropriate. So the factors that I consider really as to whether a hip preservation option might be appropriate for somebody presenting to me with AVN includes these factors. And as we heard from Sim, probably the most important factor is whether the hip is already collapsed. As we can see, there's some evidence of early collapse in this X-ray. We also heard about the level of symptoms. Clearly, there's a big difference in what you might want to do for somebody who's asymptomatic, for somebody who can barely sleep or put any weight through it. We know age is also a factor that affects outcome. Most of the studies have looked at sort of 40 as a cutoff, as over that doing quite bad. And then, certainly in my experience, those patients who've got ongoing exposure to factors such as sickle disease or recurrent episodes of chemotherapy or alcohol, they tend to do bad from recurrent episodes. We heard about the classifications, and that, they all have their difficulties, and really it's that post-collapse, pre-collapse is the thing that determines it. But as we've heard also, it's the amount of the head that's involved determines how likely they may benefit. And one thing I think is really important, if you're going to do anything, then you really need to think about, well, what's still quite likely for this patient is that they're going to need a hip replacement or a hip resurfacing, and you do not want to compromise the outcome of that surgery by anything that you might do from a hip preservation technique. And that includes your non-operative medications, for instance, like bisphosphonates. So you do need to consider these. And the reality is that when I'm putting together this talk, I looked at my cohort of our patients I've operated on AVN, and it still is the fact that most patients who present to us present with collapse. And really then it's a discussion about timing of their arthroplasty that's the challenge. But I thought I'd take you through the journey of sort of my experience of AVN, of those patients who are pre-collapse over the years, as I've seen it fairly regularly. And, this was still a fairly unfortunate typical patient in my clinic, who's a young female case who's got post-chemotherapy AVN. And I saw her in 2011, and these were all the options, some of which we've heard about from Sim. And, which of these do we do and what's the evidence for? So we've heard some of that. But the reality is that even 80% of those patients who have pre-collapse when they present will go on to collapse within 2 years. So the prognosis is not good for this group of patients. And, obviously we're keen to try and help them both to prevent collapse and also to help their symptoms. Crutches, people still use crutches, but really it doesn't make any difference as to whether they're going to collapse. What it can help is obviously with the pain. And then we've heard about all of these different things that have been tried. I was involved in the Mantis, and one of the great difficulties with all of these interesting new therapies is trying to actually get high-level studies, because if you're only seeing 10% of patients or 20% of patients who are appropriate for these consideration of these, and all the patients that you see with AVN, that actually accounts to a very small number of patients, and that makes recruitment very difficult. What about core decompression? So that's probably the most familiar treatment. Well, I think the evidence probably weighs towards doing multiple small drill holes into the lesion, and that's sort of advocated by Mont, who's obviously a big figure in AVN, rather than the single 8 to 10 millimeter hole. Although again, the evidence is different. So again, use a technique that you feel is appropriate. Yep. I went in this case for the multiple drill holes. A review by Mont showed that of those patients who'd had a pre-collapse core decompression, a third actually did not then require further surgical intervention, which is, you think that, well, that's reasonable. But what we know actually is that 20% wouldn't have required any intervention anyway going forward. So the margins for improvement are unfortunately fairly limited. And then there's this recent RCT comparing physiotherapy versus core decompression, which found no significant difference. But that was in a group that was sickle, and so may not be applicable to all AVN. Now, this is this lady this 17-year-old who, I saw her some 8 years later, pain-free and happy and no further problems. So it can work. But what else can we do in addition to the core decompression? Well, we could add some stem cells, and there's some evidence, although not what I've done in using stem cells, that it can report lower progression of the disease. If you're going to do a larger diameter core decompression, or it's a larger lesion, then you can fill it. You can fill it with a non-vascularized graft or a vascularized fibular graft. And the centres that have done a lot of this have reported really very good results with the vascularized fibular graft. But when reading their paper, they have a high morbidity site, donor site problem with foot drop, etc. So not only do you need specialist techniques, but there's a high morbidity, and this is not the route that I've ever gone down. And then, of course, there's tantalum rods, and there was some big enthusiasm. Luckily, I never did any of these. And then this paper came out about how challenging conversion of the tantalum rod to a total hip replacement is. And this paper basically showed that it was a bit of a nightmare trying to take these out and convert them to a total hip replacement. I've heard also that they're pretty difficult to get in the right place. And even with these tantalum rods, a number of them will go on to collapse and need a joint replacement. So I personally don't think tantalum rods is a good idea. So, time moved on, and here's that X-ray of this 27-year-old male that I showed earlier. He was an ex-alcoholic, but he worked as a machine operator, and he was now in agony and unable to work and about to lose his job. So there was some interest at the time in this X-ream in ProDens. So I thought I'd have a look at this. Basically, it's a core decompression, but with this expandable reamer that allows you to remove the necrotic segment. And then you inject this ProDens bone substitute, which is then reabsorbed by the body and filled with bone. That's the idea. So I did him, and he was absolutely delighted. He really got rid of his pain, went back to work, and was doing really well. But unfortunately, here we are some years later, and it's collapsed, and he's now on my books for a total hip replacement. So some success, and I've done others. And, I was quite enthused by these, and they don't come along very many, these pre-collapse. But here's another patient more recently, and maybe a larger segment, an older patient, no risk factors for AVN, again in agony. Maybe not collapsed at the time I saw him. And then this paper came out from the group that do this, and they said that they'd got 76% rate of success with this technique. So I was really enthused by this. COVID hit, and he got a bit delayed, and perhaps there was a little bit of collapse, but we went ahead and filled it as such. Now you could argue I haven't been able to fill the whole defect. And here we are, 2020, not ideal filling of the whole defect. Looks okay as it's resorbed, but unfortunately he's got ongoing symptoms, and so I've done his hip replacement just a couple of weeks ago. So this is a slide that I borrowed from Marcus Banks, and the reality, unfortunately, with AVN is, do all roads lead to Rome? Well, either do they all lead to a total hip replacement or a joint replacement? Well, the vast majority do. But there are cases, albeit very select cases, in which there may be options such as core decompression. So yes, they may all lead to Rome eventually, but there are possibilities for treating these patients. But we can get good results. Here's two other patients that I saw in my first couple of years as a consultant, and here they are. I've seen them at their 10-year follow-ups. Both had AVN, both treated differently, but have both done very well so far. So my take-home message from this talk is that you can do lots of things, and lots of things have been tried. But in terms of the evidence, then there is a role for very selective core decompression and plus or minus grafting in pre-collapse only and smallish lesions. And whatever you do, do not compromise your future surgery. And so perhaps arthroplasty does remain the only effective treatment for the vast majority, but there are other options that you may wish to consider. So thank you very much. Thank you. I'll pass you back to Vikas.
Thanks, Callum. Thank you very much. So probably one take-home message from here as well is patient selection is the key. Certainly procedures work, but patient selection probably being the key for which procedure you're choosing. Also, perhaps if we were having this webinar in the eastern part of the world, we probably see a lot more different techniques being tried for these patients. So with that, we'll come on to the last talk, and that's Mr. Nikhil Shah from Wrightington, and he'll take us through his experience of AVN and total hip arthroplasty for the significantly delayed cases. Nikhil, over to you. Thanks.
Thanks, Vikas. Can you see the screen?
All good, Nikhil.
And you can hear me?
Yes, all good.
Good evening, everyone. Thank you for sparing your time on an evening to listen to avascular necrosis. I'll try and carry on with the theme presented by Sim and Callum. So the aims of my talk are to try and cover briefly about the role of an osteotomy in the management of avascular necrosis and then from my practice show you various different cases that I've treated for avascular necrosis and briefly cover the results. I have no disclosures, and I'm very grateful to my colleagues at Wrightington Hospital who have allowed me to share some cases that they have come across. So, core decompression, we have listened to Callum present some of the short-term data for core decompression. So this was a case that my colleague Asim inherited. She had had core decompression elsewhere, and unfortunately she presented with quite a challenging subtrochanteric fracture through the holes that were made for the core decompression. So you can see that this can be quite a devastating complication for a young person that needed treatment with intramedullary nail. So core decompression, not only does it not show spectacular results in the long term, when done inappropriately or perhaps when adequate precautions are not followed, can have some quite significant complications. And we have to really think carefully whether we are helping the patient, whether we are really changing the natural history of avascular necrosis, or whether we are simply doing an operation to satisfy ourselves and then potentially complicating a total hip replacement in the future. As far as an osteotomy is concerned, the interest in osteotomy was really sparked by Sugioka's paper in 1978. What he did is, he did a rotational osteotomy of the neck of the femur to try and move the necrotic area outside the weight-bearing zone. And the logic was that if intact vascularized bone can bear weight, then the non-loaded avascular area might regenerate. And certainly the results that are reported from Japan and some other Asian papers have been quite good at 10 years. Unfortunately, these results could not be reproduced in American and European studies. The other type of osteotomy that was used for avascular necrosis is an angulation osteotomy. And the flexion varus or the flexion valgus osteotomy seemed to have produced slightly better results than the rotational osteotomies. When we think of why these osteotomies might have not worked, the reasons that are thought to be is because it may actually impair the blood supply of the femoral head and lead to progression of avascular necrosis. And one of the theories that Ochi proposed is that the non-necrotic area, which is moved outside the weight-bearing zone, can also continue to collapse and cause instability and osteoarthritis. So Parvizi wrote this review suggesting that on osteotomy, if you have to use it, should really be used in young people without high BMI in early stages of the disease, with a small type of lesion, and predominantly in the Asian population. More recently, Siebenrock's group in Switzerland have tried to do a surgical dislocation followed by an osteotomy combined with a trapdoor procedure. So a trapdoor procedure is a concept where you can debride the avascular lesion and perform some autologous bone grafting underneath that. And they reported that 1 out of 9 patients were converted to a total hip replacement at quite a short-term follow-up. But the morbidity in this paper is that there was a non-union of the osteotomy itself and a non-union of the trochanter. So again, you have to really balance the theoretical benefits of joint-preserving operations versus the actual risks identified and how it might compromise an eventual total hip replacement. So if you look at the registry data, total hip replacement for avascular necrosis forms a larger proportion of hip replacements done in younger patients under the age of 30. Traditionally, these hip replacements are said to have a poorer survivorship, obviously because these are young and active patients with increased incidence of loosening and radiolucencies. Often the bone quality is poor and there are underlying comorbidities like alcohol or steroids. Also, the functional outcome of these hips may not be as good as for osteoarthritis. So these are a selection of cases from my practice where avascular necrosis has presented generally in the late stages after collapse. Idiopathic AVN is probably the commonest one that you get to see where there are no other risk factors. The patient has a lot of pain. The MRI scan confirms the typical diagnosis of avascular necrosis. Now this gentleman was treated with an uncemented hip on the left and a reverse hybrid by myself on the right. Unfortunately, the socket on the left loosened within 2 years and his pain returned. And then I had to revise it to a cemented stem and an ultra-porous material cup on the left, after which he has been quite good for about 11 years now. This is something that you must have seen commonly, an intracapsular fracture of the neck of the femur that is treated with fixation using a DHS and a derotation screw. Unfortunately, some of these will go on to an avascular necrosis, especially high energy injuries, displaced fractures, or younger patients. So the implant was removed elsewhere, and when he came to me, he did not have significant collapse. So in the earlier part of my practice, I have attempted core decompression on a few patients. I've put up this X-ray under fluoroscopy to show the technique. There are many different variations, but the way I do it is just to use a DHS guide wire or a fine drill, and the key is to make a single portal or a single hole on the lateral cortex of the femur, and then keep changing directions with your guide wire so that you don't end up pepper potting the lateral cortex, because that is what causes the subtrochanteric fracture. Unfortunately, in this case, the core decompression did not work, and within a year, I had to convert it to a total hip replacement, and that is the X-ray at 11 years. This was another similar case with a displaced intracapsular fracture of the neck of the femur that was fixed in a young patient. Now, traditional teaching has always been that if you get a young patient with a displaced fracture, you try and fix it. But I've seen a lot of patients, as I'm sure you have as well, that even though the fracture might heal, you get a lot of neck collapse, and these patients have poor functional outcomes. So always think carefully, I think, before fixing all young patients who have displaced fractures, particularly if you have combination of the posterior neck or angulation. This also unfortunately developed avascular necrosis, and the fracture healed and then converted to a total hip replacement. Part of my practice is treating pelvic and acetabular fractures, and this patient had a posterior fracture dislocation of the left hip, which I had fixed using a Cocker-Langenbeck approach and a trochanteric osteotomy. In about 3 years, he developed post-traumatic avascular necrosis, which then I had to convert to a total hip using impaction bone grafting. So in these challenging cases where the acetabulum has got the pathology for which you need to progress to do a total hip, in addition to the AVN, the important thing to remember is you have to deal with the acetabulum as a revision socket and not as a primary socket to get good long-term outcomes. In other words, whatever technique you would use for your revisions is what you have to use in these cases. This is another interesting presentation that we get many times. This is a lady who had radiation for gynecological cancer and developed quite significant osteonecrosis, not only of the femoral head, but also of the acetabulum. And she then developed insufficiency fractures of the acetabular columns. So we investigated her to make sure that she did not have any lingering cancer, and the CT scan confirmed the presence of an insufficiency fracture. By the time I could get to her for surgery, to my great surprise, the fractures had healed, which did surprise me because I was not sure whether the dead bone would heal. But she did heal, and all she needed was some impaction bone grafting and a fairly straightforward cemented total hip replacement. This was also another interesting case with an ischial tuberosity avulsion fracture that was very painful. This gentleman could not sit at all on his left buttock, so he always sat in a twisted position. Unfortunately, he was also an excess alcohol user. So you can see that the fragment was quite big, and what I attempted to do is to debulk that fragment and to fix the ununited portion back to the ischium. And initially I thought that the surgery had gone quite well, but within a year, he presented with avascular necrosis. Now, I don't know whether this was related to the alcohol or whether I caused some iatrogenic injury to the blood supply of the femoral head, particularly the medial circumflex artery. In any event, I had to convert him to a total hip replacement, and he's doing well since then. Sometimes we also get avascular necrosis in the pediatric and the adolescent population. So this patient had got his SUFI pinned on both sides, but unfortunately it failed and he developed AVN. He then had this Ilizarov hip distraction surgery using an external fixator, and then the pins were taken out. The head unfortunately kept on crumbling. So when he first came to me, I think he was 14 years old. We managed him conservatively until he reached 17, by which time the femoral head was quite badly destroyed. It's very important in these challenging cases to perform meticulous preoperative planning, counseling of the patient and counseling of the parents. And he's about 5.5 years now following a total hip replacement. So some of these pediatric patients can be quite challenging. Now, this was a patient that my colleague Mr. Oakley shared with me. She was a young lady who had severe pain and had initial pre-collapse on the left side, but AVN was confirmed on the X-ray. She had already undergone a core decompression elsewhere, but this had failed. And the question really was, even without significant collapse, whether or not we should do a total hip or not. So we decided to proceed after an MDT discussion, and these were the photographs that were taken during surgery. So even though you did not have significant signs of collapse on the X-ray, you can see that there is a lot of collapse, and the cartilage in that lesion has completely delaminated. And so she did quite well following a total hip replacement. I'm not going to spend a lot of time on the results, but suffice it to say that whichever type of well-proven prosthesis you commonly use in your practice, and if you continue to use that, generally speaking, you will get an approximately 10% failure rate of the hip between 10 to 15 years. And ceramic implants seem to be doing better in younger people. So to summarize, the natural history of avascular necrosis is invariably progressive. About 1/5 of them to 1/3 of them might do quite well even without any treatment. And so we don't fully understand the natural history of this disease. The extent of disease and the extent of involvement of the femoral head is very important in planning treatment. There are many different etiological factors, and alcohol, steroids, and idiopathic AVN is not the only reason. There are a lot of other causes that can present. Generally, joint preservation, although it is attempted in younger people, the long-term results tend to be poor. And once you get collapse, total hip replacement is probably the most reliable surgical treatment. Thank you.
Brilliant, Nikhil. Thank you very much indeed for that rundown through the total hip arthroplasty and the various scenarios. Could we kindly have Sim and Callum back for the final discussion? So we've got about 10 minutes to go through this. No specific questions coming up on the chat at the moment, so I'll probably start off. More of a philosophical question. Do you think most of us are tainted by our thought processes because we are seeing most of these cases late? Whereas if we attended a meeting in the eastern part of the world, they're talking a lot more about hip preservation procedures, but we seem to be relying a lot more on arthroplasty because we're seeing the patients late. And if that is true, then should we as a society be doing something so that these patients are referred to us early? We'll probably start with you, Sim.
Well, I think that's a valid point, Vikas. We all know the waiting times at the moment, and COVID hasn't helped things. But the patients I'm seeing now have been referred a year ago. So anyone who is, avascular necrosis has been referred on the routine pathway is going to wait a certain amount of time to see a GP. A GP sees them day one, says, this is probably a muscle strain, come back in 6 weeks, see them again, take some more painkillers, have some physio, sees them again, we'll get an X-ray. The problem is the X-ray will show nothing obvious. And then they'll go away again, have some more physio, and then they'll go through that cycle. And certainly in the UK, that's the case. And really, that's why they really need an MRI scan. But then are we going to tell everyone, the GP is going to MR everyone with persistent 6 weeks of hip pain? Now, Pete Giannidis wrote a paper about avascular necrosis stressing the importance of actually early MRI referral for these young patients. And I think if GPs if you have a risk factor, then I think it's important to be cognizant of that. And I think we're all hip surgeons. We all know that the operation that we do, which has the best results, is a hip replacement. So by the time it gets to us, often they're at that just about collapse stage, to be honest with you. And the few in your career, you might go through, you'll have less than 10 who are pre-collapse or something like that. So I generally think that's true, but I think it's difficult to get the GPs to send people earlier because of the sheer numbers that they see and the sheer number that aren't going to turn out to be avascular necrosis.
Yeah, fair point, Sim. And actually, Tim has just posted something where Tim says, do you think that the problem is more with the preservation surgery results, the focus being on avoiding a total hip arthroplasty rather than looking at the PROMs? And it may well be, Tim. So you're right there, that we're probably looking at the conversion rates rather than the PROMs, or like Callum showed, the two patients, the 7 years of good results. We're not focusing on the PROMs in those 7 years. We're just focusing that in 7 years' time, if they needed an arthroplasty. What's your view, Callum, on should the society be doing something to pick up these patients early? Should we be coming up with both guidelines for AVN?
I think it's really difficult, Vikas. I mean, I was just in a commissioning meeting yesterday for the Birmingham area, and there isn't even any consideration by the commissioners that perhaps younger patients should be treated any differently from the older patients who've got arthritis, and keep them away and from surgeons until they absolutely they absolutely need a hip replacement. So even trying to convince the commissioners that there might be a cohort of people, younger people who could do well from any form of hip preservation surgery and refer early is really difficult, because they don't know about it. They don't. So I think education, we have a lot to do about education, medical students and GPs and increasingly first contact practitioners about the identification of just young people with joint pathology, and obviously for us, the hip. So I think there's a whole amount of educational activity that we could do to highlight that actually the people who are under the age of 40, and you could argue what age it should be, need to be thought of very, very differently, because we all know that really once you're over the age of 50, and I'm very nearly there, the only thing that's going to help me from a hip is a hip replacement or a resurfacing, depending on your point of view. But we need to be able to help these people who are under 40, be it AVN, be it FAI, be it dysplasia. So I would say it's a more general thing, because AVN is still relatively rare. And out of all of the procedures, treatments that we do, it's probably the one that's the most difficult for us to treat and get good outcomes, I think, other than with the joint replacement. So I think the emphasis should be actually education about anybody who's under the age of 40. They need to be thought of differently and get to us soon, and then we'll decide what's the best form of investigation, rather than opening the panacea of everybody having an MRI and everybody being referred with, a labral tear, when there's something else going on. So I think get the patients to us quickly if they're young, if they're under the age of 40. That would be my focus.
I mean, certainly that holds true, because we opened up our center for two trials, the pre-op and the mantis. And once we opened up the center for these two trials, obviously there were lots of patients being referred in from the region for AVN who were coming in late initially. But then towards the end, we were picking up a lot of patients who had early AVN as well, and were able to actually offer them hip preservation procedures. Mm-hmm. Nikhil, your take on this? Should we as a society be doing something to focus on this and try and get patients early to us?
So I've got a more practical approach, I think, because I have trained in India. So I have seen the Asian version of it. And certainly we had a lot more avascular necrosis presenting to us. And the first differential of a bilateral hip pain was AVN rather than osteoarthritis. Now, I started my orthopedic career in 1995. And even in those days, I used to read about fibula grafting and core decompressions and the work that Vaniak and others in America had done. Now, you would think that if joint preservation surgery has been around for 30 years, 35 years, that is long enough a time for the enthusiasts to publish high-quality survivorship data of different types of joint preserving operations after 3.5 decades. And that data is simply not there. So whilst we can discuss the joint preservation surgery to the nth degree, unfortunately, without data influencing our decision management, we are still practicing opinion-based medicine and eminence-based medicine rather than evidence-based medicine. The second part is picking them early. The only time that I have picked up avascular necrosis early is if someone's presented with a painful left hip, where I've diagnosed avascular necrosis post-collapse, and the MRI scan has incidentally picked up a right hip that has avascular necrosis on the MRI scan, but that is not symptomatic. Now, because we don't understand the natural history completely, and we know that 20 to 30% of these patients will actually resolve without developing collapse, I have struggled to recommend in them a prophylactic joint preserving operation like a core decompression or a fibula grafting or whatever, because I really don't know that I will be giving them an operation that is necessarily better than if I leave them alone. And then when you work in a tertiary center, unfortunately, you do inherit a few complications of core decompression, like the one I showed, infections and a variety of other problems. And then, yes, we do become biased that, if you have avascular necrosis and the initial procedures don't work, then at least please leave them alone. because we know that arthroplasty is very reliable now. The 17-year results in the National Joint Registry 18th report published just last month, I think that's spectacular. If you look at 6 to 9% revision rate at 17 years, that's very hard to beat, really.
So, Nikhil, fair points, but the only thing I'd probably go back to is what Tim is suggesting, that, the results of hip preservation surgery may be there, but we are probably looking at conversion to total hip arthroplasty as a measure of success and not their proms. It may be that they're doing fairly well on their proms at 5 years or 10 years, but if they get converted to total hip arthroplasty in 8 years, we say that procedure has not worked. And that's just probably a different way of looking at it. Okay, core decompression. We'll probably spend a few minutes on this. We've got a question here. What's the panel's indication for core decompression in the pre-collapse patient? And will you avoid it in large lesions? Sim, size does matter, does it?
Yeah, I think size does matter. If you're looking at it, I think everything that Callum said as well, age matters, size matters. And I think if you've got an ongoing comorbidity or risk factor, so if you've got an alcoholic with a large lesion who's 50, then you're not going to offer it. If you've got someone who's 32, who's got some pain with a moderate sized lesion, I would counsel them. I wouldn't say it's the panacea for their pain and it's going to be wonderful. And I agree, don't pepper pot the lateral cortex, but I personally would offer them core decompression in these suitable patients. So again, it's only something I have done a handful of times. And that's because I think it's important to be selective. I wouldn't offer it for the large alcoholic 50-year-old personally.
What about you, Callum?
Yeah, so I'm still doing this X-ring with the Prodents in very limited cases. And I spoke with Mike Parry, who some of you will be aware. So we have our oncology service and he's one of the oncologist surgeons. And, I'd done a few of these core decompressions for the AVNs that were coming through my clinic and have presented two of those in the talk. So I'd spoken to Mike because Mike gets the ones who've got chemo side effects coming through his clinic. So, he started doing them about 4 or 5 years ago, did a handful. And we had a conversation a couple of years ago, this might work. And then I spoke to him in preparations for this talk. What do you think? And he's like, I'm still not really sure. And I think your point and Tim's point about why are we doing the core decompression? And my feeling is that in the ones that I've done the core decompression with the X-ring, I don't feel like I've compromised in the ones that I've done the arthroplasty. In all of them, it has made a massive difference to their pain and their quality of life. It's a relatively straightforward, quick procedure. I can get them in at relatively short notice and do the procedure. They can get back to work pretty quick. And okay, they might end up having their joint replacement a year or two later, but actually they've had a benefit. Now you might say, well, why not just do a joint replacement on those? But as I showed, quite a few of them have gone on for a year or 2 years or even longer. So all of the things that I said, yes, age is a problem, size is a problem as well. But I'm happy following appropriate consent process with the patient because I still remain, as we all do, if a 25-year-old comes along to say, right, well, let's just get on and do your hip replacement. I think that's the elephant in the room. Is like, it's very difficult the first time you meet these people to say, well, let's just put a joint in. And so I still have it for these still believe in it for these pre-collapse patients, even though it may be very limited and it may end up. So I think there's still a role for it and I still offer it in very selective pre-collapse patients. Yeah.
Cool. And Nikhil?
So I'm afraid I've got my biases against core decompression because of the complications I have seen and inherited and the poor results. I know they're not exactly the same problem, but this is like saying that you should put an arthroscope in arthritis of the knee joint to get 1 or 2 years of benefit, but they're going to need a knee replacement anyway in 2 years. So for me, that is not really a good enough indication. So certainly for the last 5 years, I have not done a single core decompression. If I see a young patient with a small lesion on the MRI scan and with multiplanar reconstruction, and I strongly believe that he should get the benefit of the best possible joint preserving operation that might be available, then based on whatever data that Pete G has published in Leeds, I have sent about 6 or 7 patients to him over the last 5 years for core decompression, and his technique of stem cell treatment. I think half of them have done well, half of them have come back to me and I've done their total hips. So I have to say I've not seen spectacular long-term results yet. So, I sort of remain a bit skeptical about it.
So 2:1, 2 in selected cases, and Nikhil is, well, you in selected cases as well, you're referring them to PG rather than doing them yourself.
Yeah, I mean, we live in an era where clinical medicine has to be evidence-driven, and if there's a gift for joint replacement surgery, why should there not be a gift for joint preservation surgery?
Yep.
If one person can do 100 core decompression with stem cells and do a better job, then I should not be doing 5 of them, really.
Sure, fair point. But if you're actually doing core decompression, and this is to Nikhil's point now, and you want some evidence, then we've done some work on this. We ran a systematic review, and we looked at over 2,500 hips, and full follow-up was available for over 1,000 hips. So 80% of them in early stages, follow-up of about 56 months. And if you did a core decompression without any augmentation, then 38% went on to arthroplasty within 26 months. So that's a definite published figure. So if you're thinking of doing a core decompression in early stages, then you've got to augment it with something, i.e. stem cells or whatever, bone marrow, whatever you want to put. If you don't, then even the early stages one, there's almost about a 40% chance of going to a total hip arthroplasty within 2 years. Okay, time is running out. We're having fun, but one final tip from all of you before we go. Sim, what would you like to tell the audience? One final tip.
I'd like to say, try and work in a place in a country where you can see patients early and you can have that discussion with them. Because all I seem to get is people who've collapsed, and actually it makes the conversation it's much more straightforward, and they get a total hip replacement and they're very happy. But I know for a lot of the people viewing in India, they will probably see people get hip pain, they get an MRI scan, they come and see a surgeon. So I think it's important to remember that there are other options, not just a hip replacement. And, you said 30% will need a hip replacement in 2 years, but then that's 70% who don't need, and we don't know when they will need. And if they're a young person at work, as Callum said, is 2 to 4 years, 5 years, is that good of pain-free living? So I think the jury's out there, but I think try and work somewhere where you can see the patients early.
Thanks, Sim. Callum, one tip?
Yeah, so I suppose it's in answer to the kind of complications of core decompressions. What I would say is don't have a go. I think these patients should be done by somebody who's a young adult hip surgeon. If this is the first case of pre-collapse AVN you've seen in the last 5 years, I think you should be asking your colleague who's perhaps seen them a lot more to take them on. Even me with my extremely specialist elective practice, I don't see many. But I would hope that I've got more experience than somebody who's only seen one in the last year. So I would say these actually do need specialist early referral. So send to your colleague who's doing 100 or 50 or seeing at least 50 AVN a year. So don't just think a core decompression isn't without risk, and just like doing a DHS, you need to know what you're treating and be up to date with all the options and the skill mix.
Nikhil, we'll come to you for a final tip. There's one quick question coming. Is a CT or an MRI required for detecting or evaluating collapse? Is an MRI enough, or do we get a CT as well?
I don't do CT.
Yeah.
But X-ray and MRI.
Sim?
X-ray, I agree with Callum. X-ray and MRI.
And Nikhil?
I'll do a CT if the Acetabular is involved.
Okay, so definitely no CT required for the femoral head there. All three agree, it's just an MRI. And Nikhil, your final tip for the audience.
So if you are going to do a core decompression, please don't make a big hole in the femur.
That's a good one. Right, ladies and gents, thanks a ton. We've had the pleasure of having 3 fantastic speakers. A big thank you to Sim Johal, Callum McBryde, and Nikhil Shah for giving up their time. A big thank you to all of you participating this evening, and everybody from the Asia Pacific region as well. From all of us and the BHS, have a good evening. Take care. Thank you.
Thanks a lot.